You just have the grand overview of the Healthcare Payment Improvement Initiative in Arkansas. It's gotten a lot of attention. As some of you have heard, we're one of now 6 sites that actually were recognized by CMS for implementation of payment reform. We've received a $42 million grant from CMS, one of only 6 states, and probably the only one that's not within 100 miles of Canada. The other 6 states were Oregon, Minnesota, Vermont, Maine, and Massachusetts. So we're an interesting company. We're going about this by looking at a population-based approach to harmonize incentives across payers. So that's Medicaid and Blue Cross, and to some extent Qual Choice are engaged with Medicare's interest and support. We want to reward the better providers who can provide quality care and efficient care to help us bend the cost curve. And as we've moved forward, we've had collaborative and cautious support from the Medical Society and the Hospital Association in that we've designed a system that 80% of providers are either revenue neutral or gainers in the system. So we think that we have coming up with a new way of getting people more engaged in the stewardship of the healthcare resources. We're looking at developing medical homes, health homes, in addition to episodes of care. And clearly, this group today, we're discussing episodes of care, focusing on the care of the complex newborn. Other activities include workforce development, health information, technology expansion, and greater engagement of consumers. And the next slide, again, it talks about what we're not doing. We're not talking about reducing payments to everybody across the board. We're not talking about increased copays, increased insurance premiums. We're not talking about increased utilization review and Mother May I kind of activities. And we're not talking about reducing coverage. So we're really talking about trying to change our incentives and that reward people who develop good clinical care by managing resources well. And as I've said, this has been an ongoing activity that we're trying to do where it's patient-centered, practical, not burdensome, and engaging the providers in the community to help design and own this new way of delivering health care. We basically are grafting this onto the current system. So care is delivered as usual. Everybody submits bills. So whether you're a radiologist, a pathologist, a physical therapist, a physician, you submit your bill as usual. Bills are paid. But on page 7, you see there is a principal accountable provider, which can be a hospital, can be a physician, can be shared. So, and in this particular episode, as we'll discuss later, the PAP will be shared between the neonatology team and the hospital. We then calculate the average cost for that PAP per episode, and then look at how that PAP's average cost of care, risk adjusted, compares to that of peers. So then you end up on page 8, where you have this slide that's up behind you here, where there is lines drawn across the spectrum of different average costs per care. So if you're in the pink zone on the far left, you are above the acceptable line. So you would be paying 50% per case above your costs above the acceptable line. So any costs above that would be a 50% risk share. If you're between acceptable and commendable, you would be in the neutral zone. You'd basically have given your services. Nothing else would happen. You go on to the next year. Essentially, you pass go, but you do not collect $200. And you go to the commendable zone. Between commendable and gain sharing, you would actually then be considered an efficient provider. And if you pass quality metrics, so in that green zone, you would be sharing 50% of the arrows between the commendable line and the green bar. And so that would be your gain sharing activities between the payer and the provider. And that would be up to a gain sharing limit. So there are limits to what we think is fair in terms of we don't want to incentivize complete cost avoidance. We want to make sure everyone gets appropriate care. So there is a maximum gain sharing, but the people who hit the gain sharing limit would obviously be receiving the maximum allowable gain sharing at 50% of that gap. So that's been the framework, and it's been well received by many providers in terms of being fair and incentivizing innovation and change. And again, on page 9, for each of these episodes, we have some quality metrics that you have to pass, which is to say at least not necessarily get an A, but at least have a B, B minus, so that would qualify you to receive gain sharing. There'll also be some quality metrics to track. And as part of this program, all providers are getting fairly comprehensive data about their patients and the resources spent for care, their quality metrics involved with the episode. So they're getting performance reports on their quality metrics as well as all costs spent during the care of the patient. So not just what they generate, not just what their bills are, but all bills generated during that episode that get attributed to them so they can figure out how their episodes of care compare to those of peers. And sometimes it's been very, very interesting. Some docs have found out that they're high compared to peers on radiology or on pathology or other activities that otherwise they would not be aware of had they not received the report card. So that's the big picture. So why don't we go on to page 11, which shows you the neonatal patient journey, which is really what we want to talk about today. So that basically you have a birth, and the child is either at full term or premature. If they are full term and nothing much else is going on, they get moved from labor and delivery to the floor, routine care, routine postpartum care. The mom is getting some breastfeeding consultation. There is routine testing and screening, vaccinations, risk assessments. They tend to go home. And frankly, there isn't a whole lot of interesting things going on in that episode for us to talk about today. Most of the time, these infants go home when the mom goes home. This is the vast majority of deliveries. And as we'll see, we will not be having an episode of care for this. But then you get into the other areas of interest in different forms of prematurity, or on some folks who have a full-term birth, but there are some mild to moderate complications. So not all full-term births are uncomplicated. Some may have some congenital anomalies, some may have some medical issues, some may have some obstetrical issues that need additional observation or potentially more advanced care. So those are the folks that we are going to be talking about more today. Some of them are very premature and require more aggressive care. So they may require testing, ventilator support, medication support, potential transfer before they're sent home. So obviously those are the areas that we're going to be finding of interest, and then we're going to talk about how we begin to frame episodes of care to reflect, if you will, episodes within these groups of neonates. You can see the sources of value, obviously to reduce avoidable complex preterm births. Most of that's going to be involved with the perinatal group or the obstetrical care, in reducing early elective inductions, which we have worked on in the state, progesterone treatment for people who've had previous history of prematurity, or risk mitigation like smoking cessation, disease management, diabetes care. Again, all of that will be in a different episode, more in terms of obstetrical care and prenatal care. We have issues about making sure that very high-risk prematurity gets delivered in facilities where they can manage a premature child. So we're going to be putting in place in the state, but again, not for today's discussion, activities to promote transfer of the mom before the delivery of a premature child or a very premature child in a lower intensity nursery. Then you get into appropriate intensity of services, ventilator days, blood testing, resource use, for a variety of early premature children. We'll be talking about that today. Again, transferring to appropriate settings. So when do you reduce the intensity of care and move the child back to a less intense services within a neonatal care setting where they may not need the intensive ICU care moving forward. Avoidance, obviously, of complications, appropriate use of surfactant, appropriate management of lines, appropriate avoidance of neck and other kinds of activities, and then appropriate nutritional support, appropriate mix of breast milk, breastfeeding, appropriate formula use when appropriate in these kids. So that's the big picture of value. Let's talk a little bit about the overall framework. And this is a complex picture because obviously neonatal ICUs take care of a spectrum of prematurity. They take care of a spectrum of conditions. So if you ask around and look in the medical literature, this is not well defined. And about a year and a half ago, I talked with John Bates and talked about we were interested in trying to define what's an average cost per day for a 34-weeker or a 32-weeker. And he really didn't have a real good handle on it. And he actually asked some colleagues in other children's hospitals all over the United States in his network. And the response he got back was, gee, don't know, but if you figure it out, let us know. So this is actually kind of breaking new ground. So how do you start to define this product? How do you define the problem? How do you start to segment the population and begin to actually look at what's comparing apples to apples, oranges to oranges, and care across clinical sites? So we have different intensity of ICUs. We have level 3 and level 4 units in our state. We have level 2 nurseries, level 1 nurseries, different levels of capacity, different levels of ability to deliver services, and probably different practice styles, something that really hasn't been looked at before. You know, how many blood gases a day? How many chest x-rays a day? How many days do you put people on ventilators? Really a whole lot of interesting areas that really haven't been explored. So moving forward, we began to look at the whole area of how many weeks premature is the child, what is the diagnostic complexity of the child at presentation to the NICU. So you go to the next slide, and you begin to see how we began to look at this, that we began to look at segmenting newborns into normal kids with significant or not major problems, extreme prematurity, respiratory distress, congenital anomalies, prematurity based on age, based on weight. And we began to discuss with our clinical advisory group the use of APDRGs, not as a payment mechanism per se, but as a way of getting greater granularity to identify different subsegments of populations that we could then compare how outcomes occurred, how resources are deployed, and then begin to compare this across different sites with similar populations of patients.
I don't know what the letters APR stand for.
Thank you. That's a good transition to talking through that. It's, as you know, DRGs are ways that payers often pay for facility claims. The MSDRG is one that's typically used. The APR DRG is an all-patient refined DRG that has actually a bit more granularity and clinical classification on some of the conditions. We actually came to this if I take us back now to the first neonatal work group that we had the other month, I think last time we had really good input and discussion from this group, the clinical advisors and others on the overall framework Bill walked through, which is diagnostic severity, some measure of prematurity, and the need to actually segment the neonatal population. And we spent quite a bit of time also with John Bates at Children's and others looking at different tools to do that. What would be the best way to actually find clinical stratifications and things of that sort. And so that's really where that was kind of the genesis of feedback from this group, from Children's, from others, to use this tool.